Hello, everyone. Good morning, good evening, good afternoon, wherever you're joining us from. This is Karen Bett. I work as a policy associate with the Global Partnership for Sustainable Development Data, the host of this webinar. We're really glad that you've been able to join us. At the moment, I see our attendees are 37 and they're coming in strongly. So I think before the end of this webinar, we'll have an even larger quorum. Allow me to introduce my panel for this webinar. I have with me Crystalline Steers from PEPFAR. I have Jenna Slotin from the Global Partnership for Sustainable Development Data. I have Anne Joroge from Afya Switchnet, who is going to make the presentation on the findings. And most importantly, also, I have Juliet Cheptoris from the Government of Uganda, Ministry of Health, and Torai Batasara from the Government of Zimbabwe, Ministry of Health. I'd also like to recognize Caroline Kamasaka from the Ministry of Health, Uganda, who's with us, and she'll provide some remarks a little later. So without further ado, I'd like to just open up this webinar by giving Jenna and Crystalline a few minutes to provide some introductory remarks before we share the findings of the work. Over to you, Jenna.
Thank you, Karen, and welcome to everyone. Very pleased to see such strong attendance and interest in this topic. My name is Jenna Slotin. I'm the Policy Director of the Global Partnership for Sustainable Development Data, and I'm very pleased to just make a few introductory remarks and then hand it over to all the wonderful experts we have on the panel for today. So first, let me just say a word or two about the Global Partnership for Sustainable Development Data. We were created in 2015 alongside the SDGs, with the objective of improving the production, access, and use of data to drive better decisions for better sustainable development outcomes across the entire SDG agenda. So why do we care about data interoperability? In essence, interoperability is the ability to join up data from different sources to help create more holistic and contextual information for simpler analysis, better decision-making, and accountability purposes. Ensuring that data and data systems are interoperable actually allows us to make the most of the data we have. In the context of development data, we often find ourselves talking about data gaps and the need to fill data gaps. But in fact, we know there's also a huge problem accessing and making best use of the data that we already have and data that's collected through programs and routine service delivery. And so to make a contribution to this particular challenge around joining up and making best use of existing data, we co-hosted with the UN Statistics Division what we call the Collaborative on SDG Data Interoperability to produce some guidance on this challenge for development practitioners. I want to highlight Tom Orrell, who's joined us on the webinar today listening, who was one of the lead authors of that guide. And the guide brings together good practices and examples from across the development sector, highlighting the real value that interoperable data brings to decision-making. And one of the key points and contributions, I think, of the guide that's very relevant here to DREAMS is seeing interoperability in several layers, from the technical and data layers to the human and leadership and governance layers. So for us at the Global Partnership, all of this fits into our work on strengthening administrative data records as sources for statistics to better measure progress and change lives. And as you all know, the health sector is known globally for having invested very heavily in administrative data systems and advancing this through technology and e-health. The need for data interoperability, therefore, is even more profound in the health sector. So as you hear in this webinar, we partnered with PEPFAR to document some good practices and lessons on data interoperability for the DREAMS partnership in Kenya, Uganda, and Zimbabwe. Because DREAMS aims to bring together multi-layered healthcare services to holistically support adolescent girls and young women, it offers a really good example of significant experimentation across multiple countries in the use of interoperability for tracking the delivery of those layered services. So I'm very much looking forward to the discussion today and to hearing about the findings from this work on the DREAMS partnership. We hope the findings will be useful to your organizations and will help us to advance data interoperability, whether we're looking at it from a governance and leadership perspective or from a technology perspective, or the standards dimensions of data interoperability. So with that, I'll hand it over to Crystalline Steers from PEPFAR to say a few words. Thank you to everyone for joining us today.
All right, thank you so much, Jenna, for that really clear explanation on interoperability. Good morning, good afternoon, everyone. Thank you all for joining this webinar. My name is Crystalline Steers McCrum, and I am the Data Revolution Lead at PEPFAR. PEPFAR is the President's Emergency Plan for AIDS Relief. PEPFAR got its start in 2003 and has invested over $85 billion in the global HIV/AIDS response, saving over 18 million lives, preventing millions of new infections, and accelerating progress towards sustainable control of the HIV/AIDS epidemic. PEPFAR has been pleased to serve as one of the foundational funding partners of the Global Partnership for Sustainable Development Data. And as an organization centered on data, as we are here at PEPFAR, we really value GPSDD's work on making the opportunities of the data revolution available to and for all of humanity. And of course, specifically where it concerns Sustainable Development Goal 3.3.3, the end of HIV/AIDS and other devastating diseases. So today, GPSDD and AFIA SwitchNet will present the findings of its review of one of PEPFAR's key programs, the DREAMS Partnership. And the DREAMS Partnership was announced on World AIDS Day in 2014 and focuses specifically on reducing the structural factors that make adolescent girls and young women particularly vulnerable to HIV. And these factors range from gender-based violence, exclusion from economic opportunities, and a lack of access to secondary school. And so in order to measure this and to address this, the DREAMS Partnership layers services from different sectors that address these challenges and more. So educational services, economic services, health services. And so the focus of the webinar today is on the ways that PEPFAR operating units, and specifically in Kenya, Uganda, and Zimbabwe, have measured this service layering. As you can imagine, triangulating data from a variety of service providers and sectors is incredibly challenging. So, you know, this is really important because this data interoperability from all of these different sources really underpins PEPFAR's ability to effectively monitor and evaluate success. So, you know, I know what we're all really excited to hear about the findings from AFIA SwitchNet's review, and then hear about these best practices and any resulting recommendations. So thank you very much.
Thank you so much, Crystalline and Jenna. I'd like now to move to Anne to share the findings of the work. And just for your information, if you have any questions, they will have a Q&A button right at the bottom strip of Zoom, but we also can use the chat button to share your questions. So, and also for your information, we're recording this webinar and this will be available after this on YouTube. So without further ado, Anne, I'd like to pass this over to you. Thanks.
Thank you very much, Karen, Crystalline, and Jenna for the introduction. My name is Dr. Anne Njoroge. I'm here representing AFIA SwitchNet, which is a consultancy firm that was working in partnership with GPSDD in conducting this case study. And I'll start by saying that this report was funded by a grant from the United States Department of State. Opinions, findings, and conclusions stated herein are those of the authors and don't necessarily reflect those of the United States Department of State. Having given that disclaimer, I'll talk about the work that we did in the 3 countries, starting with the rationale for the case study, the approach which we used, the findings, the opportunities of improvement that we found, and I will conclude with a couple of recommendations. So, despite substantial declines in new HIV infections globally, the HIV/AIDS epidemic continues to disproportionately impact adolescent girls and young women. Specifically in sub-Saharan Africa, approximately 67% of annual new HIV infections are among adolescent girls and young women. So the DREAMS Partnership, which is led by PEPFAR, is an ambitious public-private partnership which seeks to reduce this rates of HIV among adolescent girls and young women, who in future I may refer to as AGYW, in the highest HIV burden countries, some of which are listed here. And the DREAMS Partnership promotes a multi-sectoral approach, as Crystalline has alluded to reduce the vulnerability of AGYW. And this is through a core package of interventions that target multiple sources of HIV risk, with the aim of promoting determined, resilient, empowered, AIDS-free, mentored, and safe lives. So these interventions include address structural factors such as gender-based violence, exclusion from economic opportunities, and a lack of access to education, as well as offering referral and leakage services to biomedical prevention services. And as of 2019, data from these 10 countries implementing PEPFAR's DREAMS initiative showed that the new HIV diagnosis has reduced by up to 25%, and in some places even more, in all the regions implementing this initiative. So, as I've said, DREAMS approach focuses on layering these multiple interventions at once, so that the girls and young women are surrounded with critical support to keep them safe from HIV and other risks. And this layering occurs across multiple interventions and different sectors like health, education, and social welfare. As you can imagine, tracking this can be complex. A key DREAMS hypothesis is that providing these services as a package is more effective than any single service in and of itself. And so to test this hypothesis, it is critical to understand both the numbers of services these girls are receiving, the extent to which specific subpopulations are getting a comprehensive package of services suited to their needs, and who is actually offering these services. So some of the things that the systems track include unique individuals. We're talking about layering of services, as well as tracking this across various partners. So questions that we seek to answer include, DREAMS seeks to answer include, are services reaching specific subpopulations of AGYW as intended? And when the girls are referred, do they receive the service for which they are referred? So with this in mind, GPSTD and PEPFAR identified the DREAMS initiative as an example wherein significant experimentation has taken place across multiple countries towards interoperability, data interoperability for tracking delivery of layered services. So the case study rationale came through, in this way. The interoperability guide is a practical guide for organizations and institutions to incorporate interoperability as they design and implement data system. Using this as a lens, this case study was commissioned to distill notable practices in developing and using interoperable data systems alongst those lines of stakeholder engagement, the policy and regulatory frameworks available to govern this, as well as infrastructural requirements. Successes and lessons learned in both system development as well as system use, and identifying areas where there still are opportunities to support interoperability. And this is with the aim of enabling development of interoperable data systems for adolescent girls and young women across DREAMS landscape, and to inform similar efforts in other contexts. So with those as our objectives in mind, this was designed as a rapid qualitative assessment for maximizing on time and efficiency, with the entire assessment happening within 6 months. So we started with doing a desk review of available literature focusing on interoperability and layering of services amongst DREAMS partners. And then this was followed by a stakeholder mapping in trying to identify who are the key players within the DREAMS ecosystems who would be best placed to give the insights and information that was needed. This included a mix of both state and non-state actors, implementers, and to some extent beneficiaries. We then went ahead to design the data collection tools, and we relied heavily on the GPSTD interoperability guide, but also borrowed from other tools that are out there, or other frameworks that are out there that refer to interoperability of systems. And in particular, we leaned heavily on the HIS interoperability maturity framework developed by Measure Evaluation with funding from USAID. We then went ahead to do to collect the data, and this was largely done through key informant interviews of the stakeholders that we mapped. We also were able to do focus group discussions in Uganda and Zimbabwe, involving in particular the implementing partners, and in some cases the community-based organizations that actually interface with the recipient adolescent girls and young women. And we went to the field and saw how the people on the ground are interacting with the system. So be it data entry, be it analysis and data use to some extent within the community, we were able to review that and see that for ourselves. With regards to analysis, the interoperability guide, and when I say the interoperability guide here, I'm referring to the interoperability guide as I described earlier, developed by Tom Orrell, who is here, and others within GPSTD. It outlines interoperability as a conceptual framework, and the 4-layer lens it outlines. We thought these 4 layers overlay or converge fairly well with the 3 main domains as described by the HIS interoperability maturity assessment framework. And so we thought this could be used to distill the extent to which systems are designed with interoperability in mind. So the 4 layers are largely the technology layer, which essentially speaks to data being available in standardized interfaces. Then we have the data and format layer, talks of technical standards and data structuring. The human layer that alludes to common understanding among data producers and consumers. And then the institutional organizational layer that refers to responsibility and accountability across the data lifecycle and value chain. Given the programmatic context of DREAMS, we also focused on leadership and governance as a domain prescribed by the HIS interoperability maturity framework. This was not necessarily with the aim of scoring the maturity of the DREAMS systems in terms of interoperability, but using the subdomains therein as a lens to interrogate to what extent they've influenced data interoperability within the DREAMS systems. So I'll now move to describe our findings. So as a brief description of the program implementation, for those who may not be familiar with the DREAMS program, the girls may enter into DREAMS through a variety of entry points. While each of these services, the minimum and the secondary packages that we referred to earlier, has its own focus and assessment tools, the program has guidelines to ensure all partners and all service entry points provide these basic steps which are common across all the partners in all the countries. So there's screening and eligibility assessment, and then if eligible, a girl proceeds to be enrolled. She receives the service that she seeks or that is appropriate for her in her age and her situation. And then if that is not available and she needs to be referred, then she is referred and linked to the next available service provider who can offer the service. In terms of program structure, so the funds flow from PEPFAR through the main agencies, then these fund implementing partners, many of whom go on to fund community-based organizations who are the front-facing people within the community, but a couple of them also engage directly with the DREAMS beneficiaries. At the level of the implementing partners in each country, there is one who is designated as the monitoring and evaluation partner, who is responsible for design and maintenance of the DREAMS data system. So with focus on the systems, Kenya developed what they call Kenya DREAMS database, a custom-made web-based system using open source technologies, and this included the Django development framework and the Jasper reports for reporting. Uganda and Zimbabwe use the DHIS2 tracker, also known as the DHIS2 community module, which is an integrated module within the global DHIS2 system. But they have different names for it, as you can see. In terms of similarities across the systems, I will highlight only these, but there are many more as details in the report. So for all the three systems, they are able to capture referral through standard forms, and in fact, in all the three countries, they use the same form that is provided by the Ministry of Health. Access to the data within the system is rights-based, depending on the user role. All the three systems have a way of uniquely identifying the beneficiaries, and this unique identification system was system generated in Kenya and Uganda, and in Zimbabwe, the unique identifier is generated using an app following a certain logarithm. And all the three have offline data collection capability. In terms of differences, I'll just highlight the two which both use DHIS2. For the Uganda system, while all the partners have a similar login interface, the Zimbabwe system, they have partner-specific login interfaces. And as I had already said, the two systems use different ways of generating a unique ID. So through the technology layer, each country cited technical standards in light of future interoperability as one of the factors they considered while developing or adopting their DREAMS systems. And these include HL7, FIRE, or aggregate data exchange. DHIS2 underlying design accommodates commonly used standards and profiles, and from standard development organizations. And Kenya system also reported being aligned with the FHIR standards. And so that's just a quote from one of the partners in Uganda. This was the reason they chose to go, this was one of the supporting reasons why they chose to go the DHIS2 route. Again, under the technology layer, we thought that having both online and offline capability allowed the system to be available for use at all times, which is critical because complete data facilitates data interoperability. So switching to the human layer, in the subdomain of human resources in all the three countries, the various levels of implementation have officers with the necessary skills to support system use, so be it development, maintenance, or use. even for organizations using DREAMS beneficiaries as data entrants, these were required to have basic ICT skills. For capacity building, was largely focused on system use based on user roles. So users had their capacity built depending on what they were doing. What was interesting about the DREAMS capacity building approach is that it not only included the DREAMS partners, but also included the Ministry of Health officers at the district or county levels. And this really fostered use of the system or data from the system by these officers. I'll mention data quality review meetings here because they foster continuous improvement in data quality. And these are scheduled across the 3 countries. Well, they have different iterations, but there's a schedule for entry, cleaning, and review. And this is enforced by the MNE partner. And this ensures that the data therein meets certain quality checks and would be readily interoperable with data from other systems. Let me mention an interesting indirect effect of DREAMS data use. That's been fostering partner cooperation amongst implementing partners. I'll give an example of Uganda. They organized themselves outside of PEPFAR supervision and agreed that for consistency and minimizing duplication and therefore correct attribution of numbers to the respective implementing organization, only they have a lead partner in each district, and only that lead partner would generate unique IDs and share this with the other partners during the monthly data review meetings. So that's fairly uncommon within the PEPFAR setting, but this has given rise to that. For the institutional layer, we chose to focus on stakeholder engagement, in particular government engagement. Details on organizational structures supporting things like data sharing agreements, licenses, and MOUs are detailed in the report. So in the 3 countries, the MNE partners extensively involved state as well as non-state actors in the development of the data collection tools. And this resulted in really government-owned forms and registers, which were then eventually input into the electronic systems. It also led to implementing partner-accepted reporting processes where everyone follows the same process, and meaningful participation in data review meetings by everyone involved in the data generation as well as use value chain. And that's just an example of a register that has the Ministry of Health logo, but is specific to DREAMS to illustrate how this engagement led to government ownership. There has also been significant support and encouragement of government officials to utilize DREAMS data as official data. And you can see there, sorry about that. We see there that government officials actually have access to the data. And this one person from Zimbabwe says, "Oh, how I wish this were the same for HIV data." And this stakeholder engagement with government, fostering government ownership of DREAMS systems, fosters adoption of interoperable systems in the public sector. Again, using an example of Zimbabwe, having involved the ministry and the National AIDS Council in the early days, increased ownership and appreciation of the complementarity of the DREAMS DHIS to the national aggregate DHIS. And now they have funds outside of PEPFAR to roll out a similar program to DREAMS. And they are adapting the DREAMS DHIS with the help of PSI Zimbabwe there and adopting it to suit their program and needs. So again, another example of how engaging stakeholders, particularly the government, can lead to adoption of interoperable systems. For a system to provide information that can be used effectively across organizations or systems, data from interoperable systems must first meet the needs of the primary user. In this case, the data from dream systems actually allows them to calculate this indicator, AGYW PREV, which is what they are required to report to PEPFAR. And since the systems are designed to capture single data elements consistently, this means that for the most part, even when the definition of this indicator changes, it doesn't affect client-facing the elements. And so this can actually facilitate retrospective evaluation using current definitions, because you just need to go back and use the different combinations to come up with your indicator. Another major success with the DREAMS data system has been data demand and information use from the implementing partners. Notably, there has been demand and consumption by, as I said, government officials, including district level and community health officers, especially in Uganda and Zimbabwe. You can see that they actually say, one community health worker said, with UDOTs, I can see whether a girl I referred to another partner actually went, and it's good because then I'm confident that we've helped that girl in the best way possible. More so, they use the data to monitor their performance using reports and dashboards at various levels. And there is no more excuse that that is not our data because the data is in the system. So this, again, with ownership and them feeling that the data meets the requirements, people are inspired to actually use the systems, and the system ends up having all the data that is needed to track the service layering that is the core component of DREAMS. And now to the contextual glue that holds all these layers together, leadership and governance. I won't go through the 8 domains as listed in the interoperability maturity framework, since some of them are not applicable when you narrow down to program level systems. But starting with policy, the 3 countries reported having an e-health policy and other relevant policies. They reported having adopted the OpenHIE framework, for their national HIS interoperability development, and are at various levels of ensuring compliance with data exchange standards. These policies state that ideal digital health systems should be affordable, easy to scale, and meet the needs of the users. And as a global good, for example, DHIS2 lends itself well to this requirement. With governance, the DREAMS partners are members of the e-health technical working groups that are available or that are in existence in all these 3 countries. And when they sit in these CWGs, they share their insights and experiences with the ministry as the ministry seeks to develop interoperability guidelines, frameworks, and even their use cases. With regards to standards, DREAMS systems meet the international data exchange standards. And then with regards to data ethics, some of the ways in which the DREAMS data systems have demonstrated consideration of data ethics includes, the role-based access and use of unique identifiers that have minimal collection of personal identifiers within the actual system. And with regarding business continuity, they all have formal data backup processes and procedures at various levels. So again, this goes to show that all these components of leadership and governance are instrumental in supporting development of interoperable data systems. So now let's talk about where we observed opportunities for DREAMS systems to demonstrate interoperability or enhance their features in support of future interoperability. And the first one would be that DREAMS is in a unique position to establish a robust, unique identification system. With the current identification systems that they have, there's a likelihood of duplication, where you have the same girl appearing with multiple ID numbers within the DREAMS database, as well as lack of verification, because some of the algorithms are known even through the recipients. And so it's possible to circumvent this and allow a girl to pose as a beneficiary multiple times. And so given its unique ecosystem, DREAMS has the capacity to demonstrate the viability of creating and implementing a unique identifier, preferably with verification within these data systems, and be a leader in the settings where they are to demonstrate that this is uniquely possible. The other thing, the other opportunity that DREAMS has as a program is in defining a maturity pathway to a fully paperless system. As you can see to the far left, that's how the paper tools are, and these are required to be filled by all the partners. And then that is then transcribed into the system. And that's the comment that we got from a lot of the people who engage in this work. And so given the fact that the DREAMS system has both online and offline capability, I think the DREAMS program is in a unique position to inform other programs and provide insights to the ministry on how to gradually mature systems to go paperless. I'll talk about the opportunity to standardize training curriculum for sustainability and ownership. The current training on use of the systems is fairly ad hoc, in the sense that it's as and when needed. The training schedules and content are really user-driven as opposed to skills-based. And there isn't much involvement of the ministry in terms of content development for this. And so developing a standardized formal curriculum for DREAMS data systems with involvement from the ministry e-health governing bodies would be critical for sustainability and ownership of these systems once PEPFAR moves on. Another opportunity is leveraging programmatic convergence to promote system interoperability. And here I'll focus mostly on the two programs, the DREAMS and the Orphans and Vulnerability Children programs. And so because of the convergence in programmatic implementation in terms of the services that they offer, there is an opportunity for DREAMS to influence or to have the systems that they're bringing on board for the OVC programs be interoperable with the DREAMS system. So Uganda has already proceeded to include the OVC program in their DREAMS system. However, the Ministry of Gender and Social Services also has a different system separate from the DREAMS one. And so being able to facilitate discussions to see whether these two systems can actually exchange data would be an opportunity for DREAMS to demonstrate system interoperability with other systems. And then data exchange with existing national HIV prevention programs. And these are specifically for Kenya, where the National AIDS Control Council already has a community AIDS program reporting system, but that system and the Kenya DREAMS database are not directly linked. And so the data from Kenya DREAMS data should actually be reflected in CAPR, but it is not. And so that is an existing immediate opportunity where data interoperability can be demonstrated. And so in conclusion, it's evident we can say that DREAMS data systems meet the needs of the program in the sense that they're able to track layering across of unique individuals across services and across various implementing partners. In their design, DREAMS data systems have considered and incorporated elements supporting interoperability, as we have gone through using the two frameworks converging. There are opportunities for immediate system interoperability with other systems, as well as just data interoperability, which can be explored. Effective leadership and governance, as well as partnerships functioning within an enabling policy and regulatory framework, are critical in fostering interoperable ready systems. And even final conclusion is that there are practical frameworks that can be used convergently in the health sector to inform interoperability in health data and health system design, implementation, and evaluation. And with that, ladies and gentlemen, I thank you for your audience. I'd like to acknowledge AFE-SwitchNet, which has allowed me to represent them, the Ministries of Health of Zimbabwe, Uganda, and Kenya, and this includes the National AIDS Control Councils and the National AIDS programs within these countries. I would like to acknowledge the partners who really assisted us in conducting this case study. These are the M&E partners for the respective countries: PSI Zimbabwe, Uganda METS program, and the UCSF Kenya Global Program. I'd also like to acknowledge the agencies, CDC, USAID, and DoD, for linking us to the appropriate stakeholders and organizing for us to get the data. And of course, thank the US Department of State through the Global Partnership for Sustainable Development Data for not only funding this work, but creating this webinar as an opportunity to disseminate the work. Thank you.
Thank you so much, Anne. I believe this was an excellent presentation, lots of findings to process, and I know we've received some questions, one on the chat, some in the Q&A. So we'll definitely get into Q&A right after this next session, which is going to be brief. And I think before we move that to that session, I just want to recognize also Steve Wanye from AFE-SwitchNet, who worked with Anne in this project, and also Joshua Gitonga from the National AIDS Control Council, Kenya. So the next session, I'll just invite Juliet from the Ministry of Health Uganda and Torai, Ministry of Health Zimbabwe, to just for a very brief exchange, just sort of hearing from the hosts at the country level, your experiences on data interoperability, and also thinking about the next steps. So what some of the lessons we're taking from DREAMS, and how do we take that to strengthen health systems within the country. So without further ado, Julia Torai, I believe you're here with me. So I'll just pose the questions, and I think I'll start with you, Torai. The role that you play actually sort of linking PSI with the Ministry of Health in Zimbabwe. And I'd like to just hear from you some of your country experiences, of course, learning from DREAMS, and what you found as some of the biggest gains or some of the biggest lessons in regards to data, strengthening data and data interoperability, reflecting on the DREAMS work. Over to you, Torai.
All right, thank you very much for the opportunity, I think, to be part of this discussion. Indeed, I think the issue around interoperability of systems is very critical. I think for us, I think as a country, as Zimbabwe, when we look at issues around making sure that we put data to good use to inform, I think, programming, to inform, I think, whatever that we are doing as countries. But I sit within the Ministry of Health as the DREAMS coordinator within the Ministry of Health and Child Care in Zimbabwe. And the role that I am doing there is to make sure that I coordinate the partners, or a consortium of partners that are working around DREAMS implementation in the 6 districts currently that we are working with. So I think if I'm to jump quickly when I think around issues to do with, I think, the DREAMS, the DHIS tool that we are using in Zimbabwe. I think for us, I think within the ministry, this has been a game changer in terms of what we can do and the levels where we can push the DHIS2 system to be able, I think, to do for us. We are using the same system within the ministry to capture patient level data. But what we've been able to do with the DHIS2 system for DREAMS is completely different from what we are doing with the DHIS2 that we are using as a ministry. So what we have been doing, I think, within DREAMS using the DHIS2 right now, I think, is being able to tell us a story in terms of if we are able to identify an adolescent girl, we give a service. We're able to track that same adolescent girl across partners that are giving different services within the consortium or within the district, which is totally different from what we get, I think, when we go to a health facility. We give a service, I think, to an individual. At the end of the day, we are only able to tell, for example, if we have given probably maybe 100 or 1,000 adolescent girls and young women a particular service, for example, maybe it PrEP or family planning. But what we are not then be able to tell within the system that we are using as a ministry is to be able to track if it is the same girl that has received family planning services this month, next month, or maybe in the months to come, or in the previous months. So what the system that we are using within DREAMS is able to tell us is we're able to see if it is the same girl that has come and received PrEP within the DREAMS consortium, if it is the same girl that has been able to be sent to school, have received education subsidies, or have participated in the ISALs, which is good for us because I think the thrust, within DREAMS is for us to be able to layer services on each of the adolescent girls that we are finding, that we are coming across within the community. So that story alone, to be able to say how many services have you received, how many unique services have you received as an adolescent girl, from which partner, and within the system we are also being able to track referrals across partner to say, okay, if it's PSI, how many adolescent girls have you referred to FHI? If it's FHI, how many adolescent girls and young women have you referred to the next partner? So this gives us an opportunity to be able to track along the consortium the kind of services that adolescent girls are receiving from each of the partners. And this also gives us an opportunity to close those referrals across the partners that we are working with. So that alone we have not been able to do with the current system that the Ministry of Health is using. So when we jump into issues around opportunities, this is a good opportunity for us, I think, as a ministry, to say we have seen what the DREAMS DHIS2 is able to do for us. But what is it that we can borrow from there and make sure that the system that we're currently using can be able to do that for us? I can give you an example. When we look at programs for intervention such as ART, what we are just able to do at the end of the day, we are able to segregate it to say, okay, how many adolescent girls or how many young women are on ART? But we are not able to further disaggregate to be able to tell a story to say, okay, of the adolescent girls and young women who are on ART, how many probably are in school, how many are, probably are into sex work, or how many are in other activities? So that story alone, we are not able to break it down within the DHIS2 that the ministry is using currently. A good example, I think, is around PrEP. We know that PrEP, we are giving it to people who are at substantial risk of getting HIV infection. But within the DHIS2 for the ministry that we are using, we are not able to further segregate or break it down to say, okay, how many of the people that received PrEP, how many probably are MSM, how many are female sex workers, how many are serodiscordant couples. What we just able to tell is we have given PrEP to so many people, how many are females, how many are males. So that story alone, to be able to track and to be able to see and segregate further in terms of population types, in terms of the services received, in terms of all those services that are being given across partners, it's something that we appreciate, and it's something that we are very excited of when we look at the DHIS2 that DREAMS is using. So for us, I think as a country, it's an opportunity for us to be able maybe to, in the future, to be able to upgrade the system that the Ministry of Health in Zimbabwe is using, to have the same ability that we find in the DHIS2 for DREAMS, such that all the interventions that are happening across the country from the facility, from the community, we are able to pick it within the DHIS2 that the ministry is using. But what we have allowed, I think, in the country in terms of when we look at issues to do with governance, is issues to do with the policy. The policy that the e-health policy, I think that the ministry has, allows different partners that are in the either in the HIV sector or who are providing different health services to be able to run with their own systems, but with the ministry able to monitor and track whatever that happens within those various systems. And we have been fortunate enough that I think the partners that we work with are cooperative enough to be able also to give us credentials, the logging in passwords for their systems that they are using, so that we can also be able to access the data that they are using within their various systems. So it would have been ideal if all these systems that different partners are using would be able to speak to the DHIS2 that the ministry is using. So it would be good for me just to enter into the system, just log in and be able to see data from different partners that that would have been entered into their own system. So the issue between, issues around interoperability is still very limited, because we still have partners, using various systems. But the good thing is that we do have a good working relationship and we are able to access that data in any time when we need that data. But otherwise, the Dreams DHIS2 that we are using right now is able to tell us a story, able to track the services on individual girls that would have received the services. We are able to tell a story in terms of the services that are layered on each of the adolescent girls that are receiving services within the program. So for us, I think it's a good platform, a good learning platform for us as a country. And I think moving forward, we will explore opportunities that are available to make sure that the two systems then speak together, and to be able to make sure that if we log into the DHIS2 for the ministry, we are then also able to see the data that is within the DHIS2 within Dreams. So it's something that we're still discussing and something that we'll explore going forward to make sure that all the systems that are working within the country are speaking together as far as data collection is concerned. So I think it has been an exciting journey for us as a ministry, and we'll continue to explore ways of making sure that the systems that we are using speaks together.
Thanks.
I think
Thanks
that's what
so
I can
much.
say for now.
All right, thank you so much, Tora. I appreciate, and I think you've combined the questions, so like your experience and also some of the next steps. I'd like to move to Juliet. Maybe Juliet, you can take the same approach, just give your country experience in terms of what you found as the biggest gains or lessons interacting with Dreams, and then reflecting that on strengthening health systems moving forward as the Ministry of Health in Uganda. Juliet, over to you. Maybe you can take about 5 minutes before then I'll invite Caroline.
Okay, thank you very much. Good evening, everyone from this side in Uganda. It is evening. I want to thank everyone who has joined the call, and also PEPFAR and the entire team that organized and collected the information. I think the report is very interesting, bring out very interesting ideas that we will need to discuss further as a country. Thank you, Anne, for documenting Uganda so well. We really appreciate. From my side as a coordinator for the Dreams program here in Uganda, just to add to what my colleague from Botswana said, that for us, the Dreams program and the way data has been collected and the world is help to access services has been so exciting, and I think it has given birth to joint interventions in a very multi-sectoral way. For example, the Dreams program has really taught us how we can work in a multi-sectoral approach in practice, looking at what education can do, what gender can do, what the Ministry of Justice should be doing, and what Ministry of Health should do, looking at only one girl who is vulnerable. And I think most of us are very conversant with the statistics in Uganda that the adolescent girls and young women are more vulnerable to HIV infection than any other population. So what has this given birth to for us in a multi-sectoral approach? We've moved away from having clustered meetings of different line ministries to one joint adolescent girls and young women technical working group, which brings together all the other line ministries, and we sit at national level to discuss the data and see have we met the targets, where are the gaps, how can we handle them, once we get information from the METS program like Anne presented. Also, we have the implementing partners in the different regions, others are implementing programs focused on education, others on health, others on social protection and socioeconomic strengthening. We've now had to have joint performance review meetings as a country, and we meet quarterly to look at our statistics, getting information from the program from METS, and also comparing with what we see from our DHIS2 as Ministry of Health. I want to say that the data that we pick from METS is not a duplication of what is in the Ministry of Health DHIS2. All that we need from DHIS2, we get it from there, but we have specific data for layering that we get from the METS program. So we have performance review meetings with all our donors, plus all the line ministry staff at national level and the district representatives, including the adolescent girls and young women themselves, like Anne had presented already, that we've had to have the girls participate in data collection and train them and give them iPads to help us to enter the data such that we have timely data, but also for them to understand what we use this data that we collect with. And then also very important that when the DREAMS program started, it came as a pilot, and as a country we are very eager to learn what comes from this unique data that we pick in a layered way. And it quickly gave birth to what we wrote as the Global Fund Catalytic AGYW grant, which has now moved to about 16 districts. And then we've had reviews that have been happening in the very first districts that we started implementing the DREAMS program in the country. And we've started to see a magical reduction in the incidence of HIV among adolescent girls and young women to about a reduction of 45%. So what have we done as a country with this very beautiful information? We have written our very first adolescent girls and young women HIV prevention strategy as a country, which we have completed. And we have learned from the innovations that we've seen from the DREAMS program and picked and worked together with all the other line ministries to have a joint service package. And we know that once we have that service package, we have defined from that is working together with our umbrella agency, Uganda AIDS Commission, learning from what we pick from the METS data system. We've developed a harmonized adolescent girls and young women AGYW framework for M&E, and we are in the initial stages. So we have consulted all the line ministries, Ministry of Gender, Ministry of Education, Ministry of Justice, Ministry of Health, to look at the data that we pick jointly, such that we put this in a government system that we can keep collecting, and the only middle agency is Uganda AIDS Commission. So we have a draft framework right now, and we're working very closely with METS and all the other agencies to see that this becomes a success. So just to talk about following on with the data quality audits that Anne talked about. We felt that now that we are looking at one adolescent girl in a layered approach, we stopped doing fragmented supervision, and we developed one tool, and we called it the Dreams Quality Assurance Tool. And it has all the service standards from the different line ministries and what data should be picked and what services the girls should be getting, such that when we move from national level to a district, we are moving in with all the stakeholders from national level to those districts. And once we reach that district, we work with the different departments, again mirroring what has happened at national level. So those are actually the learnings that we get from the multi-layered approach that we have learned from the DREAMS program. So, so just to add to what actually Anne had said, those are the unique things that Uganda brings to the table in terms of implementing the DREAMS program. And next in our line of implementation is to write out our scale-up plan. And we are calling it the Adolescent Girls and Young Women State Scale-up Plan. And we want to make it as informative as possible. And I think Anne's report gives us some of the information that we should use to write the scale-up plan. And we are in the initial stages of just doing consultations with key stakeholders. So I think that is what I can say for now from our side in Uganda. Thank you. Over to you.
Thank you so much, Juliet. It was really interesting, and how you've sort of the parting shot is that some of the findings from this work would be actually useful in developing some of the strategies that you're building within the Ministry of Health. I think that for me really shows the value of this work, and also, of course, the lessons we can pick from DREAMS. I'd like to move, we have about 25 minutes to the end of the webinar, so I'd like to move to Q&A, but before that, I'd like to just invite Caroline, who heads eHealth within the Government of Uganda Ministry of Health, to just give a more broader view, just thinking beyond DREAMS at the Health Ministry of Health level, some of the experiences, or actually some of the things you've picked up from this conversation. So Caroline, I'll just let you talk for maybe about 3 minutes, and then we'll switch to Q&A. You're probably on mute, Carol.
Okay, can you hear me now?
Yes,
okay.
We can.
Good evening, everyone. Good morning, good afternoon. I'm glad to be on the call, and thank you very much, Global Health Partnership, for organizing this webinar. Maybe briefly about Uganda's journey into interoperability. We have actually made strides towards that direction. I'm happy to report that we have guidelines right now in place. We have the draft guidelines document that is being reviewed at various levels that will guide our interoperability and health information exchange journey. But we don't just have that, we have also gone ahead to develop a use case for health information exchange across different systems. We have done a use case of HIE between viral load data and EMRs. And also we are trying to do the same for EMRs and DHIS2, and then other lab management information systems in the sector. For DREAMS, we haven't had so much interaction with DREAMS as the Division of Health Information Systems. But I'm happy to note that, as Juliet said, they're already thinking about interoperability and how these systems can speak to each other between DREAMS and DHIS2 and other related systems. But also to note that the other journey that we have taken as a country in terms of interoperability is how to integrate with cross information across facilities in cross-border districts between Kenya and Uganda. These conversations have already been started and work is ongoing. I don't know if Steve is on the call, but work is already ongoing in this regard. So the journey of interoperability in Uganda has already started because we do not want to strip into innovation, but we want to have these systems speak to each other and have a seamless flow of information across these systems, but also across the health facilities. Thank you very much. That's all I can talk about interoperability right now. Thank you.
Thank you, Carol. I was really keen to have you get space to bring in really a broader health informatics view. So thank you so much for that. I'd just like to pass now, go back to my panelists for a Q&A. We have about 4 questions. I think one is a comment, and I'll start with you. And we have a question from Paul Masharia, who asked what were the unique challenges faced in bracket due to offline support, synchronizing the data to the central database, and how was this addressed? So what data exchange protocols did you find that these countries use for data synchronization? And do you want to take that question, please?
Sure. Thanks, Paul, for the question. So the unique challenges due to offline support are as expected. One was the fluctuation in connectivity and internet availability, and how partners have managed to address this is that for those that are actually using the offline system, using tablets and iPads, they tend to have scheduled uploads. So they've organized themselves in a very neat way. I'm giving an example of what I saw in Uganda, where they have specific times when they know a certain partner is supposed to be synchronizing. So partner A knows they synchronize at 3, partner B knows they synchronize at 4, and on Wednesdays, no, I think all of them were synchronizing on a daily basis, but at set times, and that they said helped, once they went that route, that helps them to avoid this issue where they all were synchronizing at the end of the day, and then the system would get overwhelmed. And I think the other thing that came up with regards to supporting offline use was just using it multiple times and finding, some are reporting they found places within their neighborhoods where the internet connectivity is really strong, and then that's where they would go physically when they want to synchronize. I think that was a report from Zimbabwe. The data exchange protocols, I think they were using, since these are DHIS2 based systems, they're using the newer version of HL7. I think that answers the question.
Great, thanks, Anne. I'd just like to move to the second question, and I'll pose this. I'd want to start with you, Torre, and then to you, Juliet, and then Anne, you can wrap up. The question is from David Ojaka. David has worked in HIV programs, and he's of course grateful for sharing the work in the 3 countries. He'd like to just know if the data or the prospects of this work in helping to assess the impact of the DREAMS intervention. So is the data collected and joined together be able to assess impact? Do we have this data in time series at individual or health facility levels just to assess quantitative impact? Torre, do you want to take this first to give Zim context on just the data you collect, and we have this in time series, and then Juliet, you can come in, and then Anne, you can sort of wrap up for the 3 countries.
All right, thank you very much. So I can say yes, the data that we are collecting, I think using the system, we can be able to use that data to assess the impact of the program. Because remember, the data that we have, I think, in our system still captures, I think, people who have gone through the program since program inception. So we are still able to go into the system and see how many adolescent girls were offered services probably maybe when the program started in 2016, 2017, 2018. We still have that data in the system. So if you want to compare, for example, if you want to compare in terms of the number of adolescent girls and young women who were reached by services in 2018 or in 2017 or in 2016 or in 2019, we are still able to see that. And you are also able to see what kind of services are adolescent girls and young women receiving more, and which areas are being addressed by those services. So we talk about vulnerability, I think, to HIV at different levels. I think Aaron mentioned, I think, something to do with primary package and secondary package. So within the system, you are then able to say, okay, of those who have received the primary package, in terms of HIV, did it address, I think, the issues or the risk to HIV infection amongst those adolescent girls? If you look at the system probably across other countries, you also then be able, in terms of the impact, you are able to tell, I think, at the program level to say, okay, in terms of impact, I think these are the changes that are happening in the lives of adolescent girls and young women. What we might not be able to tell right now probably is the issue to do with the reduction of HIV incidences using, I think, the data that we're getting within the system. But as far as probably HIV risk prevention, as far as, I think, mitigating the pathways that put adolescent girls and young women at risk of getting HIV, we're able to see that impact within the system. Because also, I think I need to mention that the primary package that we are talking about and the secondary package that we are talking about, we are then able to say, okay, how many adolescent girls and young women received the primary package? And of those who received the primary package, how many got an additional secondary package on top of the primary package that they have received? So based on the risk that we have been done initially, we are then be able to tell a story in terms of the impact that the program is making. So this gives us an opportunity to keep our data centrally, where we can see it, where we can be able to review, and also be able to tell a story using the data that we are keeping within the system.
Thanks for that response, Tora. Juliet, do you want to maybe take 3 minutes to respond from the Uganda context also?
Thank you very much for that very interesting question. Looking at the data first that we pick from the DHIS2 at facility level, it's really disaggregated in terms of age, in terms of sex, and also the types of services. When you look at, especially, for example, the DREAMS service package, which is the secondary services where we get mostly at facility level, that information is easily found at facility level and is collected in our DHIS2 very well. Most of them, including PrEP, name them. And so we are able to pick that information at monthly level, monthly, quarterly, biannually, and share it per facility. That is easily picked. And also we are able to understand which age categories of adolescent girls and young women are accessing which services, especially at facility level. Looking at the information that we pick from the UDTS, which has now included also OVC, we are able to pick individual information for adolescent girls and young women in terms of the layered services, right from the safe spaces where these girls get their services from, in terms of have they finished the correct duration of the time that they should have in terms of accessing even a service, up to the time that we pick information in relation to whether the girls who completed a certain time period have actually got all the services that they were supposed to get in that cohort. So we are able to pick that information from our UDTS, which now includes the OVC package as well. Now, I had spoken about impact briefly during before when I spoke the first time. Also, right now, working with PEPFAR with high-level packages of data analysis using the PMTCT platform, looking at ANC1 and the girls who come for services at the facility level, and triangulate that information, what we pick from our UDTS, including OVC. We're able to quickly pick information about the impact. But also in Uganda, we have very well-developed surveys that we use to collect information on impact on a larger scale as a country. Right now, Uganda is conducting the Uganda Impact UFIA, the Uganda Population Survey for HIV impact evaluation currently right now, though because of COVID, it is on hold. But right now, we should have been collecting information from UFIA, and that actually gives us information from the entire country. And we look at those districts where we are implementing the DREAMS program, and we are able to see whether actually, because the UFIA statistics give us regional prevalences and regional incidences. So we are able to quickly look at the information that comes from UFIA and compare with the previous survey and see whether there has been a reduction in terms of impact. So that's what I can say for now for that question. Over to you.
Thank you, Juliet. Anne, do you want to just come in maybe briefly just to sort of tie this together?
I think I'd say the answer is yes. Are the data collected and joined together in countries able to assess impact? I think so, yes, over time, because given the nature of the data right now, it can be used to characterize things like time to infection or aversion of infection, and so be able to assess the impact of various interventions. However, let me mention here that interoperability is critical in attributing cause. So what we're calling the quantitative impact on HIV incidence. Is it DREAMS really reducing the impact on, is DREAMS really reducing HIV incidence? So right now, DREAMS doesn't collect a denominator, and so that data needs to be connected to systems that do. So like has been mentioned, maybe those surveys or other systems that are there out there that, you know, civic registration systems that have the denominator, which is able to uniquely identify girls. And so then you can be able to actually quantitatively say DREAMS is having an impact on incidence. But with the kind of data being collected over time, DREAMS is generating what you'd call big data that can be mined over.
Thanks for that, Anne. I'll just move to the last question from Larry Spalding. Larry, it's nice to have you here joining the webinar. So Larry just wants some reflections on how differences in underlying conditions in terms of political, social, economic, technical, and institutional in the three countries has impacted different approaches to tracking DREAM services. And I'd like you to take that question before we get into closing remarks.
I'd say briefly in my reflection of this, I do think that yes, these underlying conditions have impacted the different approaches. So I'll try and contrast the two countries that are actually using a sort of similar system, the DHIS2 tracker. So when you look at how Uganda has implemented it and how Zimbabwe has implemented it, you can see you know, technical expertise and capability coming into play. So for the Uganda system, it's completely homemade in the sense that they have the capacity to manipulate and adjust the system to the level of need that they require, the METS program. In Zimbabwe, this is still being supported by an international partner, and they also get international assistance from DHIS2 from Oslo. And so that has had an impact on how they have been able to use the different analytic capacities within the DHIS2 program to track DREAMS services, even though they're using the same system. So I think that is a brief way of saying, yes, I do think that these differences have impacted the different approaches to tracking these services.
Thank you very much. And in case people still have questions which we won't be able to answer during this webinar, feel free to drop them through our email, and we'll make sure we respond to them. We're coming to the end of the webinar. We have just about 6 minutes to the end, and just in front of your screen, you'll have seen that we've launched a poll just to get feedback from you on how well we did and how we can improve future webinars. I'd like now to go back to my panelists and of course to Jenna and Crystalline to give some closing remarks. I'll start with you, Torai, and then to you, Juliet, and then I'll finish off with Jenna and Crystalline. So just a minute or so to just give some closing remarks as we wrap up this webinar.
All right, thank you very much. I think just maybe in closing, I've been saying this and I will say this, I think, over and over again, to say, I think for us as a country, DREAMS is no longer a program, but it is a concept that we are using as a country, because we now have adopted, I think, a layering approach in terms of interventions that we are giving to our adolescent girls and young women. So we have seen, I think, the good in it, on how we can work together without seeing partners, without seeing, I think, different lines that exist across organizations, because we understand that it is the same adolescent girl and it is the same young woman that we are trying to give a service. So I think with the DREAMS, it has helped us remove all those barriers, remove all that operating in silos. And I think going forward, it will also then be able to help us, I think, save on resources. Because as partners come together and work together and be able to layer services on a particular adolescent girl or a young woman, it will be able to change their lives. And it will be easy on us to be able to track that same adolescent, to track, I think, that same individual that we are layering services upon. So it gives us an opportunity as a country to save on resources by developing different systems that have got different data that is capturing the same adolescent girl or the same young woman. So I think this is an exciting opportunity for us as a country, that we are able to see what this system can do for us, and we'll be able to, we have stretched it, I think, a little bit far to see what it can do. And now we have realized what it can do. I think it's high time for us as a country to be able to adopt it and internalize it within the ministry and use it, I think, for the broader programming that is beyond DREAMS. Thank you, I think, for inviting me to this discussion.
Juliet?
Thank you very much for inviting me to this call, and I want really a lot from his discussion, and thank you so much, and for sharing the report. We look forward to seeing how we can implement the recommendations which have come from the report, and also pick the ideas from the other different countries on how we can better implement the DREAMS program in Uganda. And I want to thank all those who have given us comments, and the questions were very exciting and interesting. And also, I just want to really appreciate and say that this has been a very interactive session, especially for me. And I'll be looking forward to the detailed report such that I can share with the rest of my colleagues here in Uganda. Thank you very much.
Anne, you want to go next?
Yeah, sure. Thanks everyone for listening. Thank you to the organizers and the funders for facilitating this work, and everyone else who was involved in making this actually happen. I think for me, my final reflections is that through this exercise and through this case study, I came to realize that aside from systems exchanging data or data moving across different users, interoperability is supported by a lot of other contextual factors. And so as a program, I think DREAMS has done exemplarily well in involving the relevant stakeholders and in making sure that that support structure exists to support interoperability. And I look forward to seeing how this is moved to the next level. Thank you.
Jenna, do you want to come next, and then we wrap up with Crystalline?
Sure. Thank you, Karen. And thank you to everyone for such a rich discussion today. I certainly enjoyed it. Was lovely to see the engagement on the chat, in the Q&A, and through the discussion. And it's also so critical, I think we've seen through the comments, about the relationship between how we strengthen the data and the data systems can link to really improving service delivery and making a meaningful difference for people and in people's lives, and in this case, adolescents and young women. So really big congratulations to the team from APIA, to PEPFAR and PEPFAR colleagues for all the great work in DREAMS, and very importantly to all the colleagues in ministries of health and other parts of government that are taking this very important work forward, and all the incredible work that you're doing. It's a great pleasure from the Global Partnership to be able to analyze and lift up these stories and these experiences, and to inspire others to do the same. So thanks so much, and we'll hand it over to Crystalline now for some final words.
All right. Thank you, Jenna. Thank you, Karen. Thank you, Anne. And thank you to our panelists, Juliet, Carol, and Torre. I think this conversation really helps to capture the complexity of interoperability, but also helps to really untangle it. All of the service providers and sectors, and just the sheer scale of the people involved in different geographic locations present challenges when trying to track the layering of services. And for us at PEPFAR, we want to know, are adolescent girls and young women receiving the full DREAMS package, services from a variety of sectors? And answering this question often means that people must coordinate disparate systems to ensure that these systems communicate standardized information and in standardized formats. So it's really exciting to hear the creative ways that the PEPFAR operating units in Kenya and Uganda and Zimbabwe have done this, through designing modules through DHIS2, generating unique IDs, institutionalizing referral forms and trackers, leveraging existing systems, and then, setting up coordination bodies for that human element. And so I just want to say a huge thank you to AFIA SwitchNet and GPSDD for this thorough examination and these helpful recommendations. So thank you, huge thank you.
Thank you, everyone. I think all has been said. My job is to close this webinar, but of course, I can't close without giving a very huge thanks to AFIA SwitchNet and Jeroge and Steve Wanyi, who is online. You did an excellent job, and we really appreciate. And of course, to PEPFAR for funding this work, and importantly also to Juliet and Tara and Caroline for joining us in this conversation. This marks the end of our webinar. Thank you very much for participants who've been requesting when they'll or asking when they'll receive the final product. We should be publishing that on our website before the end of the month, which is Tuesday next week. But the exact summary is on the website already. So from me here in Nairobi, well, here in Kenya, I want to say a big thank you and a good evening, good morning, good afternoon, wherever you are. Have a nice evening. Thank you.